So we'll discuss one of the most important topic, ABPA. Can you see my screen? Hello?
Yes, sir.
Okay. ABPA. This one was a very less understood topic until the extensive research was done by PGI Chandigarh, especially Dr. Ritesh Agarwal. He has got so many publications. He was one of the pioneers in the Isham guidelines and all other guidelines. So what they have found in one study conducted by PGI people, it has a prevalence of 34.7 per 1 lakh population, in which they have screened almost 43,000 people, out of which 360 are diagnosed asthma patients by physician. So most important factor where moisture is there and all those things, water coolers, it will predispose to in genetically susceptible individuals, especially those mutations in TLR3 and IL4 and IL13. IL413 will use even in asthma biological. Same gene, it is responsible for ADP predisposition. And diagnosis is by clinical, immunological, and radiological are combined together. So when you will suspect one who has poorly controlled asthma, especially refractory wheezing, hemoptysis, cough, weight loss, these are also there, but less likely. So it is basically hypersensitivity to Aspergillus fumigatus. So many species of Aspergillus are there, but most common is Aspergillus fumigatus. This is the newer diagnostic criteria for ABPA. So predisposing condition should be there, like asthma, cystic fibrosis, etc. And obligatory criteria here, both should be present. What is that? Either hypersensitivity to Aspergillus fumigatus type 1 reaction, not type 3, immediate hypersensitivity, and elevated Aspergillus fumigatus specific IgE. So how much should be the cutoff? It should be 0.35 kAU per liter. And elevated total IgE greater than 1000. And other criteria, at least two should be put there. What is that one? Aspergillus fumigatus precipitating antibodies or IgG. How much it should be? More than 27.9. It is 28 or 27. And radiographic abnormalities consistent with ABPA, like what are the radiographic findings you will see? Finger in glove appearance, mucus, and one more most important recently they have added is hyperattenuation mucus. Here, the density of the mucus is should be compared equivalent to that of pectoral muscle or whatever muscle it is. That much dense it will be there. So when HAM criteria is there, other criteria need not be present. Only specific IG is elevated, then also you can diagnose. It is the diagnostic criteria, but it is not present in all patients. It is specific but
Sir,
not sensitive.
eosinophil count more than 500 may be historical mean.
Maybe
हिस्टोरिकल मतलब क्या सर?
पहले भी था तो
अच्छा,
ऐसा एलिवेटेड आईजी अब भी रहना, इस्नोफिल काउंट मोर देन 500 पहले भी था, ऑलरेडी ट्रीटमेंट पे आ गया तो जरूरी नहीं है ना, दैट्स व्हाई. What do you call this criteria? Isham a Greenberg essential criteria. Then one criteria which I was there as a student, it is Patterson's criteria. It has 8 components. RTPX code is A for asthma, R for radiologic infiltrates or whatever it is, bronchiectasis, all those things, and T for skin test tube, type 1 hypersensitivity reactant, E is for eosinophilia, P for precipitating antibodies, which is greater than 27. Okay. I for IgE, total IgE greater than 1000. Nowadays they are considering even 500 also. And C for central bronchiectasis. As for aspergillus specific IgE, which should be more than 0.35. So that criteria is more specific but less sensitive. Here. Modified Isham criteria, which we are following now. When I was student, it was Patterson criteria. It was 81% sensitivity and 98% specific. Modified Isham's ABPA criteria is almost 100% sensitivity. They have mentioned, but range is 96 to 100, and it is very much specific. That's why they are, because they were missing so many cases of ABPA based on Patterson criteria. This is the criteria for ABP. These are the various studies. So why we are taking specific IgE? Because here it is the answer. Sensitivity is 98.2% and specificity is also about 70%. So that's why we are taking first specific IgE or skin test pricking, because nowadays nobody is doing. That's why we have removed that skin testing to aspergillus antigen. We are using specific IgE. Okay. And total IgE. This criteria, you can take photo or screenshot of this. This one, very important. This one.
Sir, when one we are testing against aspergillus or sir, IgE or IgG. So
Yes.
why take both antibodies? Why not only one IgE or IgG?
No. Both you have to take. Because specificity will increase. If you take only one, that specificity 100%, it will not be there. It will be reduced further. That's why. Here we are taking any two of these. IgG, radiographic or eosinophils also. So which conditions IgE and eosinophil is also raised in other addition to ABPA, common conditions?
Sir, eosinophilic lung diseases, parasitic infections,
First, you have to tell parasitic infections. Eosinophilic
parasitic
lung diseases are very rare, and specifically TPE. What is TPE?
tropical pulmonary. Tropical
Hmm.
pulmonary.
When I was MBBS student, everything they used to tell us TPE only. I have remembered very much. And any fever case, they used to tell malaria, and they used to start empiric anti-malarials also. Of course, now some areas, rainy season will start like that, but not that much common. So some diseases will decrease, become less prevalent with time. That's why. TPS were very, very common, I have remembered. Now, because of increased diagnostic imaging, now we are considering more of ABP. So other conditions associated with eosinophil and IgEs, TP you have to tell first. Other parasitic infections also, of course. And third one, rare causes. Eosinophilic lung diseases will not have raised Ig. You will have eosinophilia, not Ig.
Drug, sir.
What
And
is
also,
EGPA? Short name.
granulomatosis is polyangiotic.
Eosinophilic
Drug,
granulomatosis with polyangiitis. Former name is Chag-Strauss.
that's
There also
yes.
Ig will be very high and eosinophilia is also very high. But there eosinophils are invading tissues and causing disease. They are so much elevated. Here it is not that much. It is restricted to lung. And here it is caused by aspergillus.
Atopic condition.
There we are not having any specific, only auto C and
In other
papilloma.
atopic, in other atopic conditions, IgE will be elevated. No?
No, need not be.
Uptake area.
I've seen so many patients. If you do specific IgE, it will be elevated. One patient was I think I had seen in care or somewhere, he was having severe wheezing, but IgE was normal. Sometimes IgE will be normal, but specific to that allergen, we don't have facilities. Even US also. Only common cockroach, house dust mite, and what they will do? These two are common. Food allergens, of course, they are not this. So it is basically a hypersensitivity reaction to presence of aspergillus in our body, and mostly type 1, which causes destruction, and type 3. So this is the diagnostic criteria and sensitivity. You can take the photo of this one. This one is not for exam purpose, but practical purpose. Here you can see IG is 98% sensitive. That's why you will use 98. And IgG is 94. Both if you combine, so it will be almost nearer to 100 along with IgE. Mucoid impaction, especially ham, is if you have ham and other criteria become less important. Only specific IgE is elevated, then also you can diagnose ABP. Slides, my slides are moving, or shall I keep it in? Can you see?
Yes, sir. Move हो रहा
फुल मोड में डाला तो मूव हो रहे
हो रहे हो
या अब
अब नहीं हो रही सर
ना
अब
हो रहे
16 का
यहाँ
स्लाइड है अब 16 का स्लाइड दिख रहा था डायग्नोस्टिक परफॉर्मेंस
अच्छा अच्छा वो फुल मोड में मूव नहीं हो रहे थे ठीक है
अब हुई
डायग्नोस्टिक
आप हुई
मिनिमम में डाले तो हाँ यहाँ है देखो और one
हो
more
रही
diagnostic criteria I've told you ना previously they were taking 1000 now they have reduced to 500 also. Dr. Ritesh Agarwal sir of PGI Chandigarh. So what is the sensitivity and specificity? Patterson criteria is 80% sensitivity to almost 100% specific. Since sensitivity is less, they have taken Isham criteria and modified Isham criteria. The one which we are following now, 2 SN major and out of another 3, 2 should be present. That is modified Isham's criteria. These PGI Chandigarh people are part of that criteria. This one is highly complicated, no need. And what are the newer tests we are doing? Recombinant aspergillus fumigatus antigens also they have done. Since it is very costly, so they are not using. Aspergillus fumigatus one they are using. And treatment, most important is treatment. So how do you classify ABPA? First is acute stage, next is remission state, third is exacerbation, relaxing stage, next steroid dependent, finally fibrotic stage. Acute stage, how do you define? If you know a baseline value, it should rise by more than 50% from baseline. Okay.
Okay.
But sometimes you don't know. That's why you will take absolute cutoff. What is his baseline? You don't know. So above 500 is elevated. This specific IG is 0.35. That one is very important. No need to check from baseline. Only total IgE you will use for monitoring. Diagnosis you will use specific IgE. And most important backbone of treatment is glucocorticoid and that prednisolone. So how you will use, what is the dosage? There are two theories. One is 0.5 mg per kg. One more is 0.75 mg per kg. So what they have found out, is there any difference means Just 1 minute. One minute. Hmm. So low dose and high dose. What they have found is there is not much difference in relapse rate, and also side effects are more with high dose. What do you mean by high dose? 0.75 mg per kg. You are going to use it for 6 weeks. After that, gradually tapering. In low dose, you will use zero point 0.5 mg per kg for 2 weeks, followed by half of 0.5 mg is how much? 0.5 mg for next 2 weeks. After that, you have to reduce this gradually. Okay. So there are not much difference in relapse rate. So they have found these PGI Chandigarh people only have conducted. So there is no point in using high dose steroid because it is associated with so many complications, especially what are those? Osteoporosis, gastritis. Of course, opportunistic infections will be there if person is diabetic. Otherwise, these two are most common complications. And cataracts. These are important complications. And one more thing, I'll show you this slide. Previous, some people will say combine both steroids plus antifungals, but these PGI people only conducted Dr. Ritesh Agarwal. What they have found is there is not much benefit in combining steroids plus antifungal. It only adds to toxicity. Relapse rate is very minimal difference, so no need to add in first episode of ABP. If patient has relapse, then you can add. And one more thing, what they have conducted trial between itraconazole versus voriconazole. Voriconazole is almost 5-6 times more costly, and side effects are also very high, especially hepatotoxicity tolerance is very poor. So they have found relapse rate, not much difference is there between itraconazole and voriconazole, whereas tolerance is very well with itraconazole. These slides I will show you. This itraconazole versus prednisolone in the acute stage of ABP. Two-user exacerbation rate is similar and occurrence of side effects are higher with prednisolone group. So itraconazole is a safer alternative in patients who cannot tolerate steroids. And one more trial they have conducted with voriconazole and prednisolone. Response rate are similar and 1 year exacerbation of rate is also similar and frequency of side effects is also similar. And one more thing, they have combined prednisone and itraconazole combination. What they have found, exacerbation rate is less. But is it statistically significant? No. So they have found there is no need to combine. If somebody is having relapsing disease, then you can combine. Otherwise, there is no need. It adds only to the toxicity. So what are the principles of ABPA treatment? Glucocorticoids form backbone of treatment. And antifungal like itraconazole or voriconazole are good drugs and very well tolerated. And itraconazole is having less side effects and less costly. Cost remains very important factor in our place. And combination is recommended only in patients with high risk of recurrent exacerbations or who cannot tolerate steroid doses, higher dose. So in that patient, you can combine. Especially what they have found, bronchiectasis in greater than 10 segments or peripheral blood eosinophil count greater than 10,000 and fungal bone. In these patients, they have very high risk of recurrent exacerbations. More than 10 segments means almost extensive bronchiectasis.
So even on diagnosis, first diagnosis, if you are finding extensive bronchiectasis,
You have
eosinophils
to
more than
straight
1,000
away you
means you
have
will.
to go for combination. That's what they have mentioned. And peripheral blood eosinophil count more than 1,000, straight away go for any three of these things. This is done by Dr. Ritesh Agarwal, sir. Because when we, in especially in our setup, these people will come to tertiary care center very late. So in those patients, you have to combine straight away prednisolone plus itraconazole because voriconazole is very costly and tolerance is also a problem. Especially which what is the toxicity with voriconazole? So
Sir, hepatotoxic.
hepatotoxic antifungals. Even this one, I have seen what you call ninditanib. One patient has developed severe raised OT and PT, so we have to force to withdraw the drug. Some people they tolerate very well, but we cannot predict. That's why.
Okay.
And follow up. How frequently you will follow up? Clinically, radiologically. Of course, radiologically will take time and IgE. So you will not use specific IgE or IgE for monitoring. Total IgE is important for monitoring. How you will know whether patient responded or not? Clinically, wheezing is there, symptoms are there, it will be reduced and fall from baseline more than 25%. You can follow every 8 weeks. Some say situation it is not possible, so at least for 2 visits you have to follow every 2 months. If it is falling by more than 25%, then you can consider it as responding to treatment. And if it is not falling by less than 25% after 8 weeks, then you can think that patient is refractory. You can slightly increase the dose or slightly means 0.75 mg per kg. That therapy you can follow, or better to add itraconazole instead of increasing to higher dose because higher dose of steroids has very high side effects.
Itraconazole 200 mg BD or OD, sir?
BD. They are conducting OD study also. I will find out papers. Uh, And what are the newer treatment options? As I have told you, it is associated with elevation in IgE and eosinophils. So what you will give? Eosinophils, which biologicals will act better?
Anti-interleukin 5
Anti-IL-5, very good. Like
or this mepolizumab,
mepolizumab is very much better.
benralizumab.
Mepolizumab, even though it is IgE, it response rate is poor in asthmatics also, and also ABP also it is poor. I don't know why.
Benralizumab, yes, sir.
But mepolizumab, works very well. Wonderful drug. They will have
Mepolizumab is wonderful drug,
only
sir.
thing is mepolizumab. Even asthma patients also severe uncontrolled. Only problem is cost and when to stop. That is the biggest problem with allergy. The moment you stop after 2-3 months, they will have, because they are addicted to good quality of life, they will tell, I have much worse life after stopping this drug for 3 months. Previously, I was better. Why? Because they were addicted to severe symptoms. Some, just like somebody is traveling on bike, suddenly you give him Mercedes for 3 months, and again you ask him to come to bike, he'll find it horrible now. That's why I think. Mepolizumab is a very wonderful drug in asthma. And now, even this thing also came, dupilumab. Dupilumab is also working very well. I have one receptor. It acts on IL-4 receptor. And benralizumab, problem with benralizumab is it decreases eosinophil count to such a low extent that because eosinophil main function is to fight parasitic infection in tropical country like India, so it will be like double-edged sword. That's why people are very benralizumab reluctant to use in our country. So what are the stages of ABPA? Acute exacerbation stage, remission stage, recurring
Exacerbation.
stage, recurring. Next, steroid dependent. Finally, it's
Fibrosis.
just same like sarcoidosis. Sarcoidosis is also like that, no? Third stage is infiltrates will start. After that, it will end into fibrosis. Steroid dependent, when you will call, if you reduce the dosage of steroids by 25 to 30%, patient will have worsening of symptoms. That is called steroid dependent. So nowadays they have got these biologicals, so people are not going into fibrotic and all those stages. It's rare, but of course some people they will go in spite of all those things, but they are not good. Due to this, when to start combination treatment, this study they have given very clearly. Where is that slide? Upfront, you have to start combination in these patients. Extensive bronchiectasis, 10 segments. Peripheral blood eosinophil count more than 1000 or fungal ball. You have to start upfront combination therapy.
Sir, itraconazole duration of treatment is also same
Yes, same.
6 weeks, sir.
6 months, 6 months, 6 months, 5 to 6 months. Just same like sarcoidosis, minimum 5 to 6 months.
तो
Some people have
इट्राकोनाजोल को कैसा टेपर करना सर? प्रेडनिसोलोन को
इट्राकोनाजोल
तो
को
पॉइंट
टेपर नहीं करते, स्टेरॉइड को टेपर करते, इट्राकोनाजोल को नहीं, बिना टेपरिंग करे। बीडी देके ओडी पे ला लेना लास्ट 1 मंथ में, उसके बाद
सर
बंद कर दो।
ये सैप्स को कैसा ट्रीट करना सर? सीवियर आस्थमा और फंगल सेंसिटाइजेशन, उसको भी प्रेडनिसोलोन लंबा देना?
इनोफिलन थोड़ा लंबा देना उसको भी।
तो
6
कितना
मंथ
सर?
में
जैसे कि
बिना
अब इसमें 2
थोड़ा
वीक्स
हाई डोज इनहेल कॉर्टिकोस्टेरॉइड देके लंबा देना।
एबीपी में 2 मंथ्स देना है सर?
नहीं, 6 months, 5 to 6
6
months.
मंथ 6 मंथ
हाँ, 6 months, just like sarcoidosis. It is like sarcoidosis only. Sarcoidosis का younger brother समझ लो।